networks. Again, here there's some shallow fluid, and then the FIPED or the shallow irregular, which is the diagnostic OCT sign corresponding to an OCTA vascular network underneath. So in pachychoroid neovasculopathy, you'll have and this, the angiography shows a lot of information, but it is diagnostic. The OCT is diagnostic. The next condition would be, in this patient, we have a lady who presented with 6-6 vision with some alterations and there's no fluid, but a slight amount of elevation over there. And on the network, you could see a small vascular network. And this is the presence of a CNVM in the absence of exudation. It's a non-exudative CNVM, a critical diagnosis nowadays. Here you see some alterations over here. And again, a diagnostic, you see an elevation there and corresponds to a vascular network, a non-exudative CNVM. And why is a non-exudative CNVM important? About 8 to 15% convert to a full-blown CNVMs in a year, so you need enhanced monitoring. So OCTA defined this condition. In the absence of exudation, OCTA defined this condition and is essential for the diagnosis. Again, another example where you see a large area of RP alterations and a peripapillary non-exudative. Now talking about MACTEL, we all know about MACTEL. You can see pigmentation, and you doubt whether this is a proliferative stage. Here you see vasculature in the avascular zone, but this is still not a CNVM. This is because of the subsidence, that is the downward shifting. Because of the downward shifting of the vessels because of atrophy, and this is still a non-proliferative with vascular invasion. It's a new concept to deal with. And here you have a lesion where you see an SRNVM, and again MACTEL. FFAs are confusing because you have the MACTEL leak and the CNVM leak also. OCTA clinches the diagnosis. A typical example: a CNVM in a MACTEL patient. So this is just to show that the avascular zone has the it has the vascular network in the OCTA. Depth resolution is one of the biggest powers of the OCTA. And here you see a leak. You don't know whether it is because of the CNVM or the original leak of the MACTEL, but on the OCTA you can see the network. Okay, this is the network. The next, we'll go to some vascular disturbances. We had a lady, a post-vaccination, and we saw this particular pattern. Here you see on the OCT is diagnostic. You see middle layer hyperreflectivity over here called PAM. Misnomer nowadays, but this is the pattern. See, you're using two of these imagings. You're using the NFAS imaging of the OCTA, which shows a ferning pattern, which is very typical of PAMM. And also you see corresponding flow void areas or the decrease in the deep capillary plexus layer between the superficial and the deep. So this diagnosis is the ferning pattern, and it is a feature of PAM. In inflammatory conditions, you see this is a multicolor imaging showing the green shows a bit of elevation, a placoidal type of lesion. You see the elevation over there, and you suspected a white dot syndrome. Here you see large areas of choriocapillary dropout, again diagnostic in OCTA posterior uveitis, and this was a choriocapillary and a diagnosis of APMPPE. Another person with metamorphopsia as the main criteria, a subtle disturbance of the RP level over here. The overlying ellipsoid zone is rarefied, and this was the picture. The OCTA shows definite choriocapillary voids. Again, the OCTA is very important to diagnosis. The underlying, it's a choriocapillary, but the underlying choriocapillaris is inflamed, and the overlying RP produces an RP epitheliitis called Clinched disease. Now, this is one of the main uses nowadays, a recurrence of CNVM. How to diagnose the recurrences even before you have exudation. This is very typical. You have a couple of features, a layer going around it. This is an anastomotic channel and fine fibrillary vessels. So this is a typical example. You have a line going around it. That's the anastomotic channel, and small vessels in between these anastomotic channels. So that is a typical appearance of a recurrent CNVM. Again, the same theme goes around an anastomotic channel with recurrent branches. And here you see, if you by now 2 slides later, if you got the knowledge in us, this is a part which is regressed, and this is a part which is getting reactive. It's a beautiful picture, one single picture to show both of these things. This is a totally regressed one, but over time you see frills happening at the edges. So this is how the recurrence, you can diagnose recurrence using the OCTA, again clinching the diagnosis. This is over time the recurrent area increases. So Yeah, I'm done, sir. So again, the same thing, I'm not staying on this for more than that. Again, a beautiful picture of a recurrent CNVM at the edge. This is the edge. You see a small fibrillary and the anastomotic channel around it. Okay. So just going to this. This is also an importance in not clinching the diagnosis, but identifying the different. This is a lacy pattern. This is a medusa where the central vessel is in the center. This is a C-fan, and this is a fishnet. Why are these important? The fishnet doesn't respond well to anti-VEGF. The medusa responds the best to anti-VEGF. The last is just one more slide. Secondary CNVMs, you have a lot of what do you say, fluid. This is a myopic patient with hyperreflex. You don't know it's because of a crack or lack of crack, and the OCTA reveals membrane. So for all secondary CNVMs, the OCTA is extremely brilliant in diagnosing secondary CNVMs. Thank you so much.
Thank you, Unni. Can you tell me in the clinic, means we will have one or two questions only. In the clinic, like OCT, early fluid appearance on OCT. Now OCTA, can you identify few lesions in CNVM which you will say I will start treatment, even if there is no fluid on OCT? On OCTA findings, will you start on injections?
At present, I wouldn't, sir. The whole postulate, the idea being that at one point of time, the CNVM it doesn't always convert to activity. So at that point, it could be a subclinical or it could be a quiescent. Quiescents are thought to be protective to the RP because it's an alternate source of neovascularization.
Yeah.
Treating aggressively at that time may lead to more atrophy than.
No, 100% agree with you about this non-exudative CNV. Beautifully, you have picked up 6 conditions here. And in 7 minutes, you have shown the 6 ideal conditions here where OCTA, you cannot do without OCTA, actually. The first one, PNV, it's a highly sensitive and specific. Second, you have mentioned about the non-exudative CNV. You cannot pick up with any other entities. And third, you have put MACTL2. But I have a question for you on MACTL2 because you are mentioning about, pre-proliferative versus proliferative, wherein in the absence of subretinal heme, when you have OCTA, when you do, even in the pre-proliferative MACTL, you have ectatic deep plexus capillaries. And you have in proliferative, you see in the absence of subretinal hemorrhage, you see again this dilated ectatic capillaries. So how do you differentiate between the two? Do you have any additional signs to look at? We showed that presence of subretinal fluid on OCT is a marker of pre-proliferative. And so do you have any other OCTA markers, or how do you differentiate between the two?
So regarding the OCTA, what I would look at is that you have to look at the progression. So when you have vasculature in the avascular zone, you have to correspond it to atrophy. That is, with the atrophy, the vessels are being compressed in a very small area in the vascular zone. When you have, and then in the lower zones, the choriocapillaris zone and the lower zones, you can pick up the network. Basically, the choriocapillaris zone and the outer retinal zone, and the network is usually more fibrillary. It doesn't have the streaky, pulled up appearance. Why does the vasculature have that pulled up appearance? Because eventually the cystoids collapse and the vessels are pulled towards specific points. It's streaky away from the center. But the CNVM, in my view, does not follow these rules. They move in multiple directions. They have vasculature which is curvilinear to the center of the fovea, not only streaking out from the center of the fovea like a subsidence invasion would look like.
So just to extend sir's question, like for quiescent CNVs, we understand that we may observe, but what about the recurrences that you see?
The number of questions to as minimum as possible so that we can adjust all the time. Can we proceed? Dr. Naveen Sakuja, can you come on to the dais and use, because we given him the next chance, we will speak later on.
before he is starting.
So my question was,
Yeah, in between you can ask. By
My
the
question-
time he gets ready, you can ask the question to him.
so like we know in quiescent CNVs we will not be intervening, but what about recurrences? When we have recurrences just seen on OCTA and not on, there's no fluid on OCT. So when you have these vessels that you're seeing on the OCTA, there is a recurrence. So are you still going to wait at that time, or would you inject at that time?
No. See, the very point of recurrence is being, and the very point of OCT in recurrence is that you are capturing it earlier than the fluid production. You have that window of opportunity to prevent further damage. So I believe in future, TAE is going to change to OCTA guided TAE. That is, at every visit before you do your treat and extend, your OCTA is going to be the tool to see whether the fluid comes. You don't have fluid in TAE, but you're going to see whether the OCT recurrence has started, and that is going to refine your TAE to a great
No,
degree.
he beautifully told about the signs on OCTA, the fringes, anastomosis, and now even there is an open circuit and closed circuit pattern. The closed circuit pattern is more resistant actually.
Okay. He's ready, so